Welcome to the K in Clarity podcast. I'm the host, Mezue. During this episode, we're joined by Bob Charles, founder of MedTek. Bob Charles has been instrumental in developing integrated digital platforms that automate manual healthcare processes with the digital health and healthcare technology space. With a lifelong career in healthcare, Charles has served on incredible teams that have achieved rapid and profitable growth, leading to successful exits and positioning him as an experienced leader in healthcare transformation. Charles' expertise in healthcare automation and process optimization has enabled him to envision solutions that could take billions in operational costs out of the healthcare system without sacrificing access or outcomes. His innovative work is validated by 3 U.S. patents, with a 4th patent pending, demonstrating his commitment to evidence-based technological solutions. His leadership focuses on creating collaborative approaches to fixing healthcare for every stakeholder, from patients and providers to payers and technology partners. Through his integrated digital platform initiatives, Charles continues to drive meaningful change in healthcare delivery, emphasizing efficiency, accessibility, and improved outcomes across the entire healthcare ecosystem. In this conversation, we discuss his extensive experience in healthcare, discussing the challenges of prior authorizations and the complexities of the 340B program and the need for transparency in healthcare spending. He emphasizes the importance of technology in improving efficiency and patient outcomes, while also addressing the role of PBMs and insurance providers. Bob advocates for a shift towards direct manufacturing and an integration of AI in patient engagement, highlighting the need for a consumer-driven approach in healthcare. If this is your first time tuning in, here's the gist. The healthcare industry is buzzing with innovations, but there's a lot of noise and misconceptions out there. That's where we come in. Because of my experience in the healthcare ecosystem, I've gained a unique vantage point into the industry's inner workings. We're bringing you the conversations that typically happen behind boardrooms and strategy sessions, the real challenges, innovative solutions, and game-changing insights that are reshaping healthcare as we know it. On this podcast, we'll bring you face-to-face with the industry-leading healthcare founders, executives, and innovators. We're talking about the nitty-gritty of building and scaling healthcare companies, the hurdles they've overcome, and the strategies that have led to their success. More importantly, we dive into the personal challenges that come with trying to change a system as complex as U.S. healthcare. So whether you're a healthcare entrepreneur, a medical professional, or just someone passionate about the future of healthcare, this podcast is your backstage pass to the minds shaping the industry. Now let's have Bob tell us a little bit about themselves. Welcome, Bob, to the K in Clarity podcast. For the people listening, can you give a brief overview of who you are and what it is you do as well?
Hey, thank you for having me. It's a pleasure. Thank you for the invite. Yeah, Bob Charles. Gosh, I've been in healthcare my entire career. Actually grew up in a family of practitioners. Both my parents were physicians. So this is kind of my lifeblood. And so I kind of started doing research to start my career out of college at a hematology oncology clinic for pediatric patients. So that was a pediatric setting to ground you into healthcare, to make you into a patient advocate first and foremost. And so once I kind of did that gig for a while, went and pursued an MBA, and I wanted to run a P&L in healthcare. And so once I graduated, I got an opportunity with Express Scripts to run one of their divisions. So yeah, it's been a progressive kind of a thing since then, kind of encompassing all the different stakeholders. So like I said, I started in a hospital, in a clinic, as a provider. I then moved into the insurance side of it to be with a carrier, both a PBM as well as medical carrier in Anthem Wellpoint. Worked on the home infusion and specialty pharmacy side. So again, on the biotech pharmacy side, I've been involved there. And then most recently, I decided to get in the technology business. I wanted to give my entrepreneurial facet a little bit of a play. So developed a technology platform that we've been doing for the last 12 years. We went and pursued and obtained 4 U.S. patents. And our goal is to automate transactions and manual functions that literally happen on fax machines. Healthcare and lawyers, I make the joke, are the only ones that keep fax machines in business. And we're still using 90s technology to do things in healthcare. So kind of my background, kind of started with the Fortune 50 companies and then moved more into an entrepreneurial bent to do my own thing.
Gotcha. That's a great story. So typically here we like to do an icebreaker first before getting into everything. And so my icebreaker for you is if you had to change one manual process in healthcare, not just for efficiency, but also to really reshape the power dynamics in healthcare and and all the stakeholders involved, what would that really look like and how do you go about tackling it?
Great question, man. Passion is a singular issue that I saw throughout my career. In every place that I worked, whether it was on the provider side, the payer side, pharma, that one thing is prior authorizations. And you see this being talked about as the worst thing in healthcare. Believe it or not, one of the reasons why we saw that horrific act in New York where the dude shot United Healthcare worker was because the entrenched notion in society that insurance companies deny care. And prior authorization tends to be that one transaction that is blamed for all the kind of things that we imagine the worst about healthcare. Denying care, prolonging approval to where it costs doctors. The AMA estimates $74,000 per doctor per year in operational expenses just to do prior authorizations. Imagine that the doctor's not getting reimbursed, but they're spending $74,000 as a sunk cost to be in healthcare as a provider. And that is a pervasive cost. If we imagine about 1 million doctors, that's $75 billion in cost that is needlessly incurred on the market. Plus the perception, again, to drive somebody to do something horrific, that it's about denials. So I think that is the one place where I feel that if we can automate, make life easier, that's going to be a great boon in the power shift in society. But then you look at the individual implications. So patients, especially for these biologic drugs, which affects 3-4% of the US population. Imagine a patient went to go see their doctor and got diagnosed with a crazy disease they've probably never heard of. And they were told by the doctor that, hey, there's one drug, we can put you on it, and it might, give you a chance to beat this disease. Great. Well, then they wait 2 weeks to get approved for that drug. Imagine the pain and the consternation that that family has to go through, knowing that they got this crazy diagnosis, and the one thing that can potentially help them, they're going to have to wait and wait and wait and wait to get approvals for. So it doesn't do anybody any good, especially as a patient advocate. We have to say that is not acceptable. And then you look at the implications to pharmaceutical manufacturers. It is estimated that a pharmaceutical manufacturer, through their sales and marketing, generates a valid prescription from a prescriber. But 30 to 40% of the time, because of prior authorizations, a prescription is abandoned. So think of the cost of pharma, that if they can actually fill those 30 to 40% of prescriptions, how much more can they bring into the pot to potentially reduce the cost of their drug? So, implications to everybody, every stakeholder, pharmacies, providers incur that cost, delays upon delays for patients. Manufacturers suffer the implications of that prior authorization. And if you think about who does it really benefit, you have to kind of go back to say, does it really benefit even the insurance companies? Because those delays, again, cause this entrenched notion that they're only there to line their pockets, and they do that by denying care. So I just don't know if that is really one of those things that should be in the marketplace. I'm not saying that every patient should get any drug that the doctor prescribes. I mean, there is a reasonable expectation that the right patient goes on the right drug at the right dose, the right duration, and obtains it at the correct site of care. I mean, all those things should be things that managed care organizations manage. But if they do it at such an onerous cost to healthcare in general, not only in dollars, but in wait and delay and frustration. Again, that has to be balanced. So my answer to you, again, to change that power dynamic and to remove this kind of a notion that we're all a bunch of greedy bastards looking to just monetize themselves by denying care. I think we can absolutely use technology. Again, like I said, this is being run on fax machines and phone calls today. So we can digitize that in some fashion and make that to where it's real time, maybe even in minutes and seconds instead of days and weeks. How much profoundly can we change the marketplace, expectations, reduce cost, and really, like I said, get the patient the right drug when they need it. So I think that is the one thing that I am extremely passionate about. I've spent the last 12 years trying to come up with a technology stack that addresses prior authorizations and automating it in a digital way to, again, remove these profoundly dangerous notions that this is causing in society and with the entire healthcare market.
It's heavy stack, but I think you mentioned a lot of great points there, and I think there's a lot of aspects, especially the prioritizations, as you mentioned, is definitely something that should be looked at. And I have many thoughts around it. So I think that's a great point to start off with. I think going from there, I want to transition into your early career. I know you started with hematology, oncology, and 340B programs, and so how did you really see things? Working on hemophilia and HIV, and working on access and try to change systematic inefficiencies in distribution. How did you kind of face that, and can you just tell us about your journey there?
Yeah, I think it's imperative that we learn from history, that we kind of understand the intent behind 340B, for example, and then view that longitudinally and say, this is where we started. This is what the intentions were. But where are we today? Is that, again, fulfilling the mission of the program? So, back in the late 90s when I started in hematology oncology, PB was just coming around. If you recall Ryan White, to whom the whole legislation is named after, it's the Ryan White Act, he was a young man with hemophilia. And in the 90s, we had this huge problem with a tainted blood supply. So when you have hemophilia, basically they distill down the clotting factors from donated blood, and they supplement the patient that lacks that protein to help them to stop a bleed. So when the blood supply in the 90s was tainted with HIV and hepatitis and all these other diseases, unfortunately, a lot of these boys ended up not only with hemophilia, which they were born with, but also HIV, also hepatitis C, and it became a train wreck. And also in that time, this is way before Obamacare, there was something called lifetime cap. So you signed up for insurance, and based on a family's usage, your benefits were capped anywhere from $4 to $5 million per family per lifetime. So these boys were running through hemophilia factor transfusions. The cost of that would basically exhaust their lifetime cap, $4 or $5 million in a few years. So by the time they were teenagers, the family has lost their insurance through commercial carrier, and they have to end up on Medicaid. So this was this trigger, if you will, to say people are suffering. The cost of care is so onerous that we have to do something about it. And so the market created what was called the 3B program, which was to help these clinics obtain these drugs at a massive discount, 40, 50, 60% off the going price. They would then mark it up to whatever the insurance would reimburse, and they would keep that margin. But back in the day, that margin could only be used for that clinic that derives that revenue. So in our case, hematology oncology, all the dollars from our 340B program had to be kept within our clinics, so we could use it for salaries for doctors and nurses and researchers. We could do outreach with it. We could do research with it. We can help people fund their out-of-pocket costs, but it had to be segregated within that clinic. Fast forward 25 years now, and we're seeing the funds generated by 3B going into the general hospital's fund, and it's diluted. We don't know. There is no transparency in how those dollars are used. And typically, the justification is like, we didn't have those dollars, this hospital's going to go out of business, and we're going to create a healthcare desert. And that's the rationale to justify those funds going into the hospital's fund, general fund. But again, the intent was to help patients acquire these expensive medications at a reasonable, affordable price. So I think we've lost a lot of that, between when it was initiated to where we are today. There is no transparency surrounding how these dollars are spent. And again, the questions, and rightly so, need to be asked, is it really benefiting patients? So I think, there's a lot of things with the 340B programs as they've evolved over time. I still think there's a need for it. I think if you ask hospitals, they'll tell you, especially critical access hospitals in rural markets that may have 30, 40, 50 beds, that without 340B funds, they would be out of business, and rightly so. That's not an exaggeration. Same with federally qualified healthcare clinics in inner cities, city health departments, Indian healthcare on reservations. All these different facets are, again, being subsidized and supported by 3B revenue to, if you pull it, you're going to create massive healthcare deserts and markets. But on the other hand, don't we need full transparency into how these dollars are being spent? And is it really helping patients? So that's a conundrum we're facing with the program today. And you're seeing almost on a daily basis legislation being forwarded by either the covered entities, the hospitals and the clinics, or by pharma manufacturers saying, hey, I'm discounting this program, but I'm seeing, the same patient being filed in by the PBM for rebate. So I'm double paying on discounts. Or the patient that's on Medicaid, who I'm paying a rebate to Medicaid, is now accessing drugs 3B, and now I'm being double dipped on rebate. So that's sustainable on the pharmaceutical manufacturer side. So they're pushing back. So we're seeing a lot of this angst in the market, but really no solutions coming out of this to where somebody looks at this in a very, very holistic way and say, look, we want to preserve the intent, which is to help patients that cannot afford these expensive medications. Period, full stop. How do we do that without causing all these aberrations in the market that literally causes, consternation on everybody from a stakeholder standpoint? How do we manage to that? And we've not had that kind of a rational discussion other than filing lawsuits against each other. And in the meantime, patients that need that kind of subsidy and that kind of support are kind of the ones that are left to twist in the wind. Also keep in mind that B is projected to overtake Medicare Part D, like in dog. It's going to be larger than Medicare Part D in 2 years, making it the largest governmental drug program in the marketplace. So given that sort of growth rate with 340B, it just seems like we just kind of need to kind of go back and say, why do we create this program? Why is it here? What is it intended to do? And are we sticking to that mission of helping poor people who are underinsured or uninsured access these medications? Is that intent being followed? Or is this just another money grab that, different entities are getting into the business to make money and line their pockets while the patients are going without? So I think that's the conundrum we're facing with this. And it goes back to my early days when we first started with 340B to kind of see it from that perspective to today. And I can categorically say, I don't know if the patients are actually being helped, which was the intent.
I know with, your experience, you pioneered, exclusive, limited distribution agreements. And so, the lessons that you learned in that era, especially everything that you just mentioned with your early career, how do you think that really ties into today's battles, with PBM reforms and, transparency? What does that look like?
Yeah, it's so funny. The transparency issues with PBMs really kind of derive from the fact we've separated the medical benefit from the pharmacy benefit. And that delineation just causes everybody to take one side or the other. But we know patients are not, one-dimensional, where it's just a drug. Well, they're also facing disease. They also have other things that are being built to the medical side of it. And so when we first did the first limited distribution exclusive arrangement for a biologic, it was because we were able to take the medical component with nursing and the physician piece to manage through side effects, to make sure they don't show up in the ER because, they didn't manage a side effect that was predicted properly, along with the dispensing side of the pharmacy to be able to do refills, make sure they got their medications on time. They were trained to do things like self-injection. It was a marriage between the medical and the pharmacy. And that's what helped us to win that deal was because we were able to bring nurses and pharmacists working in tandem to really improve patient outcomes. End of the day, it was about the patient reaching an endpoint in their journey that says, yeah, this drug did what it was supposed to do. The patient, the doctor, the pharmacist, the nurses, they all did what they were supposed to do. And we reached this endpoint that says either they were managed, they were cured, whatever that endpoint is. We reached it, and here's the data to show the compelling reasons why we reached that endpoint. What's happening today is the absolute opposite. We're drawing this silo between medical and pharmacy, putting those benefits in their own walled-off silo, and they don't talk to each other. There's no coordination. And what is lost is that outcome, that we're not marching towards making that patient well, whether it's to cure that disease or to make sure they can live with the disease on a chronic basis for the rest of their lives, and do it with wellness, not just suffering, but wellness. So we've lost a lot of those kind of goals that should come from healthcare because we're drawing these benefit delineations and separating pharmacy from medical. So yeah, it yields to a lot of opaque behavior. It leads to a lot of things that, again, were not intended. Mostly that the patient outcomes have been completely forgotten about. And it's literally about, just get the scripts out to them. Whether they take it or not, we don't care. The medication showed up. Okay, I got that's all they care about. So we want to, again, refocus the marketplace to say, what about outcomes? Okay, we were talking about outcomes-based reimbursement, value-based reimbursement for 20 some years now. Nothing has happened because we separated the two benefits. So how do we bring that back together? And I think just doing that, number one, refocuses all of healthcare, all the providers into one thing, which is the patient outcome. And if we can refocus to that all these, non-transparency issue goes away. Because it's not about the rebate, it's not about people making money, it's about saying, did the patient improve? Did their conditions improve? Did they reach the proper outcome? That becomes the end goal versus saying, I'm going to monetize the heck out of this formulary positioning tier that I have, and I'm going to get all these rebates, and I'm going to be, fat and happy, but sacrificing the patient outcome. So I think that's really kind of the causative reasons why we have non-transparency. It's because we've drawn so many different silos and everybody operates in their own little bucket. Nobody communicates, which again leads to opaque and non-transparent behavior.
I know something that I've thought about and I recently learned a couple months back is the relationship as well between PBMs and insurance providers. Can you dive into that a little bit more? I feel like that's something that a lot of people don't know how tied they are.
Yeah, take it one step further. The same insurance carrier that has a PBM now also owns a pharmacy. CVS is a great example. They're owned by Aetna. Caremark is their PBM. They have retail pharmacies all over the country. They have specialty pharmacies. And guess what? Now they're buying doctors and buying doctor practices. So you're seeing these healthcare entities becoming so big that, one, how do you pick them apart to say, again, show me that all these different assets that you have are working together in tandem, and the goal is to improve patients' lives and improve patient outcomes. They can't because they're so walled off, they're so siloed, and each one has their own self-interest that nobody's working towards the common good, which is to improve outcomes. Yet, they're spending a ton of money. You probably saw on the opposite side, somebody like Walgreens that went out and operated a bunch of retail pharmacies. They purchased a bunch of physician practices. And again, not doing so well because they have not been able to integrate that into one cohesive kind of a model. Why? Because the vision is not there to say, what is that cohesive model going to do at the end of the day? It's about self-monetization versus improving outcomes. So I think, the more and more we allow these big healthcare entities to aggregate everything from being a carrier, which is to manage risk and pay claims, down to owning doctors and owning pharmacies and actually dispensing the medications, it is very easy to see how goals and vision can be so commingled that there is no rational basis for doing anything other than money and profit. So I think that's what healthcare always tried to avoid is I'm not doing this. I'm not a doctor, or I didn't go to school to become a doctor to make money. Yeah, it's going to give me a great income and a good living, but I'm here to help patients. I'm here to help people. And that advocacy piece is lost. And so I think, the more we see within the market, like you just described, you're seeing so much integration, so many different levels of providers being brought under the insurance bucket. You're going to see a degradation of the vision, which is to help people, help them get better, help them to stay well. We almost have a market now that actually prefers people to be sick instead of being well. Now think about that. If you're sick, there's a lot of monetization from every aspect of an integrated entity to mine that sick patient. Versus somebody that's healthy and well, guess what? There's really not much monetization opportunity other than you got a healthy patient. So we're almost putting the wrong incentives out there for healthcare. And I think it's one of the things that we can absolutely address. If everybody can come and talk rationally and sanely, instead of thinking they're going to have to go kill somebody to make change, we should be able to talk about this in a rational way to say, what is the true goal? And even, without governmental, takeover and socialized medicine and things like that, the market could come together. And we're seeing a lot of that happening with consumer-driven behavior, consumer-direct modeling. Mark Cuban is doing that with pharmacy, where it's a direct-to-consumer pharmacy now, where the pharmacy now caters to the individual who's educated and says, you know what, I don't want to pay $50 over here when I can get it from you for 20. And so the information that's out there on the internet is now making the consumers much more educated. So I think it's a really, really fertile time for us to have this discussion as a society to say, what is the intent of healthcare? Are we organized in a way, or does the government need to step in to break up some of these huge, huge entities that, again, have lost their way, break them up so they can return to what they're supposed to be doing, which is improving patient care?
That's a big question.
It is. And I don't know how to start that conversation, but like I said, it starts with an educated consumer. And I think we're getting there. Between all the stuff that's out there, ChatGPT and AI and all of this, the consumer's becoming more educated. So I think it's a matter of society saying, this is the expectation from healthcare. This is what we want to achieve. And then holding these folks accountable, whether it's through their stock price or some other means, letting it stay in the free market, but setting expectations that society says, if you don't do this, guess what? You're not going to be allowed to remain in healthcare. That should be what the government does versus, again, taking it over or whatever. But there has to be a rational conversation, and I'm hoping it comes to that soon.
That's a great point. And, I wanted to speak to the aspect as well of your work at what you're doing at MedTech. I know you guys hold many patents, in prior auth and BIBV. And so kind of how are you guys really, digitizing workflows, and what makes your guys' approach, uniquely disruptive compared, to maybe some EHR integrated solutions?
Yeah, I think the EHR integrated solutions are a huge step forward. Remember, the EHR is really a documentation engine that, remember the yellow manila envelopes that people used to keep their medical records in, and the doctors would store that in these massive, kind of file cabinets. That's now been digitized, where the record and the patient history, et cetera, resides in a singular place. But we all know that every patient sees multiple number of doctors, and they all could be on different EHRs. So data can reside in varied places to where we cannot get that holistic, picture of a patient. Did Dr. A prescribe this and that? Dr. B prescribed something else. The two doctors know what they prescribed, because there could be side effects from one medication to the next. So the EHR has been a huge, huge, huge improvement in just documentation and record keeping. But what comes out of that, again, needs to be looked at very, very keenly. So what we went and did was we went to actual doctors' offices. We started with an oncology practice. A friend of mine, his wife is an oncologist. He invited us in and said, hey, just tag along, see what they do, understand their workflow, their processes, to see where you guys can maybe intervene and improve. And we're just looking at process improvement. We're not even looking at systemic change. We're looking at process improvements just to make people's lives easier. So we went into this doctor's office, and she was a medical oncologist. So again, not radiology focused or radiation focused. She wasn't a surgical oncologist. She was a medical oncologist. And it was amazing to me to see the hassle that she was made to go through to get one single patient on chemotherapy. So let me kind of go through that because it's very instructive to understand the pain that these physicians go through. So patient has tumor X, whatever it is, and they did the diagnostics and they said, okay, it's stage 3. And so this drug is, or this combination of drugs is the most advantageous to help with that tumor type and at the stage of disease. Great. Okay, now they get started with getting that patient approved to start this regimen. So there's usually 1 or 2 therapeutic agents, and they all require prior auth, so they have to get those prior authorizations. Now, when you infuse somebody with chemotherapy, it's done on a pump, tubing, diluents. All these things are necessary to infuse the chemo safely and properly. Those all require prior auth. Then when you infuse chemo, it depresses your blood counts to where you need supportive blood factors like Neupogen and Epogen and Neulasta and things like that. They all require prior auth. Then they may need antiemetics to help with the nausea and vomiting. They may need a pain medication to help with the pain that they're experiencing. They may need a wheelchair because they're so non-ambulatory they can't, walk. Every one of those things requires a prior authorization. End of the day, for one patient, one therapeutic episode, one event, they were looking to get 10 to 12 prior authorizations. And it was taking them weeks to get all of it done in a way. Meanwhile, they were at a center of excellence in New Jersey, which means people were coming in from the rural markets to see them because they were a center of excellence for this tumor type. Imagine the patient coming and staying in a hotel, right? Typically is what they did. And then having to wait a week, 2 weeks to get this approved to start that therapy. Just across the board, the pain inflicted on providers, patients, etc. It's just absolutely horrific. And then we looked at the different prior authorizations. So the primary chemotherapy, because it was infused and clinically administered, was billed to Major Medical, which operates on a deductible. Did the patient meet their $5,000 a year? If not, there's a percentage that they have to pay. And if they did, then it's, no cost. So there's a subset of those drugs that were billed to Major Medical. There's also a subset of drugs like the Neupogen, the Epogen, the pain medications, etc., billed at the pharmacy card, the PBM. And those are driven by copays and coinsurance and things like that, based on the benefit that the patients have. Navigating through this required somebody that was literally an expert within the practice that they had to hire and almost like a navigator help the patients, go through this. Tangle, all these different conniptions as far as their benefit design. Get the approvals and start that therapy. Again, for a patient with cancer. Imagine you or I getting diagnosed with cancer and the kind of things that are going through our heads. Am I going to live? How's my family going to survive? All of this. Meanwhile, getting entangled and enmeshed in this kind of red tape, spider web of nothing but paperwork. And the doctors have to go through that same thing to just start the therapy. And forget about whether or not the therapy worked and the patient, tumor was diminished and they lived 5 years, survivability, which is the benchmark. Forget about all that. Just to get them started on their first episode of therapy was such a pain. So when we saw that, the idea was, one, we had to be able to do the prior authorizations both on pharmacy and the medical benefit because the drugs and the services are across the board. So that was one thing we got in our heads, that our solution had to be across all lines of benefit or both lines of benefit. That was number one. Number two, we have to be in the workflow, that we cannot make the physicians leave an EMR or some other means of how they're doing things today to go log on to another portal and then access the solutions we may have on a disparate kind of a portal-based access. Plus, that also allows for security breaches, as we saw in the last few months with Change Healthcare and a bunch of hospitals getting hacked and held for ransom. Again, we want to minimize access through portals to reduce hacking and security breaches. So that was the second thing we learned. We have to be in existing entrenched workflow. But the third thing we truly, truly wanted to do is to be able to do transactionally what it took on fax machines and phone calls and do it digitally to be able to scale volume. That these practices, if they were to grow, that meant they had to go hire more people and hire more people to grow. And then it was just a circle of a cost that they were incurring. So how can you use digital tools to truly be able to scale a practice to volume? Now, before COVID, nobody really cared because you can go out there and hire people and nobody really cared. But after COVID, given the lockdowns and everything we saw, scalability became a huge issue. And believe it or not, COVID was a huge, huge tailwind for us because everybody was looking for digital solutions. They wanted to get away from manual tasks that required, people and human assets to do it so they can be scalable. So all of a sudden, the paradigm shifted after COVID to truly give us a place in the market to where before they were perfectly happy to go hire another person or go get a call center and do it that way. But now I think, post-COVID, everybody's looking for digital tools. They're looking for cost containment. They're looking for scalabilities. And we came at this to say we want to be able to do a drug, whether it's, classified as a medical benefit or a pharmacy benefit drug or a diagnostic. It doesn't matter if it's within that plan of care for that patient. Any and all prior auth we should be able to do. So that's what makes us different from some of the EMR embedded solutions, which do a pretty good job on the pharmacy benefit, but really don't have much to offer on the medical side. And we're seeing, right now, if you look at drugs, it's about 75% billed to the PBM, 25% billed to major medical, the infused meds. But that's changing if you look at the pharma pipeline. There are more and more drugs coming that are going to be medically billed. They're going to be infused. Expensive medications like CAR T and gene therapy that cure disease. I mean, for the first time, not just alleviate symptoms, but cure disease with genetic medications and therapies. They're all going to be infused. They're all going to be infused in inpatient settings. They're all going to be billed to major medical. So you're seeing this kind of a shift in the pipeline as well, to where if you cannot do both pharmacy and medical, you are leaving a lot on the table. And that's what we think, with our technology and with our, intellectual properties, we're able to manage that level.
I know one thing as well that you really talk about is unifying payers, providers, pharma, and patients. And so, how do you really go about creating, win-win incentives in a market that typically is about zero-sum competition? What is the unique way that you're approaching that?
Well, like I said, you got to learn from history. And where we started literally, way back in the day was around patient outcomes. We've been talking about the last 20, 25 years about outcomes-based reimbursement, that it's not about doing a task and getting paid for that task, right? And the more tasks you do, the more you get paid. Well, that is not a good way to manage healthcare. It is not about a widget or it's not about doing X, Y, and Z to get paid. It should truly be calibrated to, I did this because I saw that and the patient got better, now pay me, right? So this entire mess that we see today in healthcare is because we've lost sight of what truly matters, which is that patient outcome. Did they achieve the proper outcome as we predicted, as we diagnosed, as we staged? And if the answer is no, then something is wrong. And so I think a lot of the stuff that we're seeing where people are competing for those finite pool of dollars is because it's all task oriented. It's all based on how many tasks did I do to get paid? How many scripts did I fill? How many patient encounters did I see? And that drives your income. At no point is anybody saying, okay, did the patient get better? So let's kind of drill back down to the 3 or 4 major stakeholders that say, what's in it for them, right? Because unless we understand what's in it for them, it's truly hard to come up with this kind of a consolidated model that drives outcomes, right? Patients, it's obvious. They've just been diagnosed with something. They want to be rid of it. They want to live a healthy life. They want to be productive. They want to be able to go to work. They want to be able to have recreation, whatever. As they see their lives, they don't want the disease to get in the way. So we know that they are outcome focused from day one. But if you look at everybody else that's treating them, not so much. The physicians, like I said, are more incentivized to say, how many encounters did I have? And that's going to drive my income. It doesn't really matter that the patient failed or succeeded with therapy that was prescribed. The doctor's still going to get paid. Pharma, the more scripts that they fill, the more, drugs that they put out, whether the drug is effective or not, pharma gets paid on volume. PBMs and carriers get paid. How many patients can I have on my roll? How many patients can I collect premiums from? Again, outcomes are absolutely not in the picture. So we kind of go through the different stakeholders and kind of say, how do we congeal all of those people's needs into one singular thing, which is the patient outcome? That should be that goal that everybody's looking to attain, which is to have, how many times have you heard the mantra, we spend as a Western nation the most on healthcare, but our outcomes are middle, right? It's mid. So how do we reverse that to say, yeah, we spend a lot on healthcare, but we should also have the best outcomes where our patients are healthy, our people are healthy, they're well, they can go to work, they can enjoy life. How do we move that dial? So I think, a lot of these things, everybody has a stake, everybody has something to gain in today's market where it's all based on volume. So we need to recalibrate payments to outcomes, which means we need to be able to gather data. We need to be able to look at a patient and say, what did you get? Who touched you? And on a weighted basis, what is each touch worth towards that outcome? So maybe the doctor has a 60% weight because they diagnosed, prescribed, and managed. The pharmacy may have a 20% weight in the outcome. The adjunctive people, nurses, dietary, whoever else is touching that patient, they should have a weighted basis to say, out of the 100% that drives the outcome, you got a 10% stake or you got a 20% stake. And their reimbursements are gathered and calibrated to, did you succeed in what you're supposed to do? And unless you have data, again, you cannot arrive at that. It becomes a negotiated kind of a settlement. But if you truly are, data driven and focus, reimbursement to outcomes, we gotta hope in hell that we can actually affect change, systemic change, and not just, again, fix a process. So that's what we're trying to do is, how do you arrive at systemic change? How do you do this instead of, two parties coming with spreadsheets and arguing and then debating and then negotiating a settlement for reimbursement? Can it be data driven to say, on this patient, you did 95% of the work, so you're going to get reimbursed at 95% of the reimbursement. That should be something that is systemically driven with the systems and the data that we can produce to calibrate reimbursement. So just imagine that scenario. If we get to that place, how much of all of the stuff that we complain about literally goes away? So that's what we're trying to do, is get to that point to where we can, not only look at consistency and transparency in the transactions, but then gather the data to drive towards outcomes-based reimbursement, which again should be the goal for healthcare.
I know this is something that I recently saw. I don't know how true this is, but when you mention, and a lot of people have mentioned, right, the cost of care and healthcare in the U.S. versus the outcome. A lot of that cost, at least mentioned in this thing that I was able to research, is essentially a lot of that cost is basically us and the cost of innovation and the solutions. We're probably one of the most innovative healthcare in the entire world. And so, but a lot of that is the burden that we kind of take in comparison, to other markets and other international markets around the world. And so, do you think that's actually true, right? That's why the cost is so high, or is that just, a symptom or something that's going on there? Just what are your thoughts in general?
I don't think that's the reason. To tell you the truth, I think that's actually the opposite. It helps us that we're not in a worse place than we are today because of innovation. But if you look at the studies that truly, truly define why do we bear the cost, you can boil it down to one thing. It's freedom, okay? In this country, we have the freedom to do whatever the hell we want. We can eat what we want. We can sit on our butts and watch, TV and play video games. We can eat what we want. We can smoke. We can drink. We can do all of these things. And all those behaviors have consequences. And so if you think about it from that perspective, do you want to take away freedom? Okay. Or do you educate the consumer to do the right things? Because the number one reason why costs are so high in the US is because of chronic disease. And chronic disease, again, can be avoided. If you think of diabetes, congestive heart failure, asthma, these kind of things, they can be avoided with proper behavior, right? So do you want the government to come in and say, like they do in socialized medicine countries, yeah, you're not going to get that because you've been a smoker all your life. Now you got lung cancer or this or that. And we're not going to pay for that intervention because your behavior caused that disease or that condition to worsen. Versus saying, look, if we lead healthier lives, okay, we exercise, we eat better, we're going to avoid these things that cause so much cost down the road. In fact, 50%, basically, of the cost of healthcare is due to avoidable, preventable things. 50%. If you can cut your healthcare costs in 50%, would you do it? And it truly comes down to what is that behavior that each one of us do on a daily basis that drives that cost. So is it the employer that's actually, negotiating and providing you with healthcare to do things to say, hey, healthy behavior, smoking cessation, diet, GLPs, the new drugs for weight loss, is that something that should be covered to avoid diabetes and heart disease? All these things become, again, societal questions that require resolution, and we're not doing that as a society. We're letting carriers do it, and each one does it differently. We're letting pharmacies do it, we're letting doctors do it, and everybody's going to have variations. So there is no consistency. But it comes down to the fact that we are a free nation and we can do whatever the heck we want. And that has consequences. But on the other hand, with good consumer education, with consumer behavior properly aligned, so much of that is easily addressable without having the innovations that you talked about to come up with the $1 million drug to cure diabetes. Well, guess what? Diabetes is preventable. So do you need $1 million drug because you did all the wrong things and now you need $1 million drug? And if you did all the wrong things and you're requiring that kind of cost, should society somehow subsidize that cost? That's what it comes down to. So I think a lot of this stuff, reasonable people can resolve. Reasonable people can affect their behavior. And reasonable people can come up with a way to say, this is what is acceptable, this is not. And we've done a lot of things, for example, with smoking to make that less of a burden, but people still smoke. Alcohol is now becoming, another thing that people are really paying attention to. But the number one thing that they say is almost on the same par as smoking is sedentary lifestyle, where we're just sitting around literally on our butts doing nothing all day long. And that sitting is going to yield tremendous consequences. You're looking at like teenage kids now that are pre-obese and predisposed to diabetes. 14, 15, 16-year-old kids. And so how do you affect change in that kind of a population when they should be out playing and never, ever should be facing those kind of conditions that leads to chronic disease? So I think a lot of this is on our own. We got to take responsibility for that in our own lives and our families' lives. And I think so much of that doesn't need to be driven by multi-million-dollar interventions that pharma has to produce. It could be something we can resolve on our own. And again, that's maybe naive, but I'm a naive person, I guess.
Yeah, I think you're speaking of something absolutely true, right? It's the individual's choice and it's one choice at a time, one person at a time. And, that may take a long time, maybe, in comparison to just building out a solution. And, that's really
You
easy.
know, there's been a lot of talk about Medicaid right now in the news about Medicaid cuts, et cetera. Keep in mind, Medicaid is predominantly an insurance for indigent people or poor people that don't have the means to get commercial insurance. But if you look at the population, it serves women and children first and foremost. The highest amount of people within Medicaid is women and children. And if you look at children especially, and women too, like, how do you make sure that they have a good pregnancy, they carry the baby to term, and they have a healthy birth, right? Because if you don't, and they deliver preterm, you got everything from asthma to all sorts of chronic conditions that result. But if you take that woman to term and make sure she has a healthy delivery, you avoid so much later in that child's life, from asthma to ADHD and other conditions. Then you got the kid that, again, society's changed and more from people being outside and playing, on the vacant lot playing baseball, all summer long, to where they're sitting and watching TV or playing video games. And they're putting on weight. They're not eating well, and they're putting on weight because of lack of activity, which again leads to a ton of disease and conditions down the road. So is that a place for intervention? Can these kind of Medicaid type carriers or the employers or somebody needs to be able to intervene in a real-time way to say, look, this is not the way to, again, achieve a healthy life, have a healthy life, and enjoy life. This is actually the antithesis of that. You're going to have problems. So where's that education going to come from? And right now, based on HIPAA and all these other things, people are so scared to say anything. And so the message is not out there carried well enough in a direct way. Like you said, how do you engage with the patient one-on-one? That could take forever. But how do you maybe get into more of a group mode, whether it's in the school systems? It needs to happen. And I just don't think it's happening. And so I think we're just setting up another generation of sick people. I mean, we're about to see the baby boomers in about 10 years are all going to be gone. Okay. Right now, the older geriatric population uses the most healthcare and costs us the most. In 10 years, they're all going to be gone. The generations that's coming behind them, they ain't that healthy. So are we going to actually reduce the costs after the baby boomers and that generation is gone? Are we going to incur more chronic disease, more chronic cost as these patients that are coming into their older age, they're not healthier. So what do we achieve as a society where one generation passes and the new generation that comes in to that end stage of life is as bad or worse from a health standpoint? That is not sustainable either. So at some point, we have to intervene on an individual basis, take some responsibility, and say, I'm responsible for my healthcare, and I'm going to do the right things because I know what those things are. Diet, exercise, etc., avoiding things like smoking and alcohol. Those are the things that I think can truly, truly move the needle. Everything else is just a Band-Aid.
Absolutely. I think as well that the community basis and having groups, that can affect and proliferate change a little bit more. So I think that's a great point that you touched upon. The next part I want to kind of switch gears to is I know one of the private equity groups that you guys work with has exclusive rights, right, in pharma hubs. And so how do you guys really think about, balancing manufacturer cost containment versus, the revenues, provider revenues as well, and really specialty drug distribution? How do you guys think about that?
Yeah, so again, we don't see that as a zero-sum gain, right? It should be something that there's a place for everybody that if you do the right things, that you should be successful in your P&L. I'm taking it down to that level. So if pharma succeeds and they fill more prescriptions, doesn't mean that the insurance markets or the employer markets need to suffer as a result, right? You would think that if pharma fills more scripts, it's for the right patient, with the right diagnosis, at the right dose, at the right duration. All those things are done properly and the patient has a good outcome, which means the employer group now says, hey, I can support that. Providers say, hey, I can support that because it was easy for me to do what I'm supposed to be doing. The whole society then says, I can embrace that. So we want to come at this and say, look, we're going to disintermediate cost, okay? By automating X, Y, and Z, these manual transactions, we're going to derive cost savings across the board. Doctors are going to save that $74,000 per doctor per year that I spoke about earlier. They can cut that down a lot, which means they're going to be more profitable just on a cost basis, right? You don't have to increase reimbursement at all. If you reduce their cost structure, they're going to be more profitable. Pharma, like I said, abandons 30 to 40% of prescriptions that they generated. If they can cut that abandonment rate in half, okay, that's like having a whole new sales force detailing doctors to generate that much more prescriptions. So they're going to make out at a lower cost. Providers, patients, out-of-pocket costs, all of these things improve to where there's a whole bucket of cost savings that are now available to the market. The question now is, what do you do with that? Okay, you can take that and line your pockets and say, okay, I'm going to return that to my stockholders and they're going to make my stock go through the roof and we're going to become billionaires and trillionaires. Great. That's a great, great outcome for you. But for society, what if you were to take those cost savings? And again, those costs are already embedded today, right? This within your P&L, your profitability, your long-term projections, and your future values are based on those sunk costs. If we were to take that out and disintermediate that, what are you going to do with that? Because your nut's covered. Why don't you put that back into things like reducing the patient out-of-pocket cost, right? reducing copays, saying, hey, patient, if you do X, Y, and Z, the doctor does X, Y, and Z, you're going to get a good outcome on our drug. And if you do all of those things properly, we're going to say zero out-of-pocket cost to you. Is the market ready to move to that? To where if we were, as a digital technology company, are able to take out costs, are we confident that those savings are going to be reinvested into reducing the patient burden, reducing the employer burden, reducing the cost of healthcare? And that's where I think that we have a little bit of a, butting at the heads, because private equity traditionally has looked at healthcare as a great place to invest because the future value is 9 to 10% greater than what it is today. It has been so the same that every year, year over year, it's been a 9 to 10% inflation on the cost of healthcare over last year. Okay, there is no supply demand. There's nothing that says, well, it could be 6%, or maybe it's a negative number where there is no growth. Every other market has to go through that except healthcare. And that's why private equity was so enamored of investing in this market, because for the last 25, 30 years, 9 to 10% year over year growth was absolutely predictable and bookable. Now we're coming to a place to say that's not sustainable. Society's saying you can't do that anymore. So if we were to save money and bring savings to the table through technology advances, through whatever means, is the market ready to put that and reinvest that to reduce the overall cost of accessing healthcare? I don't know. And I think that's something that we should ask of everybody. If there are savings on the table, what are you going to do with it?
I know health data is valuable and super important to value-based care and UB. And so, how do you guys really intend to collect supportive data, and at what level as well?
Yeah, so, well, that's two separate use cases with 340B and generally for value-based care. But I think it's going to come together at some point. But you need to be able to look at data very longitudinally because, like I said, right now data exists for a singular patient, whether it's you or I, in multiple different data warehouses and repositories. Like I said, you could see 2, 3 doctors, specialists, for example, based on what you're experiencing, and your data could reside in an orthopedic doctor's EMR, but it's not available to your internist. Or it could be in the internal medicine doctor's database, but it's not available to the orthopedist. That longitudinal data. The other thing is medications, right? The history of what you are taking is so fragmented that nobody knows. So if you go see an orthopedic doctor and they want to put you on something for, let's say, arthritis, because you're seeing, you're getting arthritis in your knees or whatever, they don't know what else you're taking that your internist prescribed for you, which could contraindicate what they prescribe. So just something as simple as saying, tell me all the meds you're on, that is self-reported. And we know how memories are. We know how we forget things. And so there's a huge missing element to just something as simple as drug history and medication reconciliations that is not available. Longitudinal data that follows the patient is something that, again, should be part of the criteria for data gathering. In 340B, we want to be able to gather data at the NDC 11, which is a code established for every drug, every presentation, every dosage, every packaging. There's a different NDC 11 code. And what we gather to support a 3B covered entity is to show that that drug for manufacturer, Pfizer, Abbott, whoever, was, number one, prescribed to an eligible patient that is 40B eligible. In other words, they don't have Medicaid, they don't have any other kind of insurance that prohibits 340. We make sure we do an eligibility check, primary, secondary, and tertiary, to show that there is no carrier that's present that is, again, not eligible for 340B. Then we make sure that the physician that prescribed that drug is 340B eligible, that they work with a covered entity, either as a staff physician or as contracted with that hospital to provide care, that there is a eligibility on the doctor that writes the script. Then is the entity itself registered with the government? Is there registration in good standing? So we make that as a check and say, okay, check. This is a 340B eligible prescription. Then we follow it and say who dispensed it. So we electronically transfer that script, e-prescribe it to only a pharmacy that's contracted with that hospital to be a contract B pharmacy. So that whole chain of custody from front to end dispensing needs to be done at the NDC 11 to satisfy pharma's requirements. And we do that now so that nobody has to do it on a spreadsheet. Nobody has to go and retrospectively pull prescription data to show that all those checks were done to qualify the patient and the prescription was dispensed by a contract pharmacy. Here's the date timestamp. And so everything's compliant to the 40B regs. So we do that now. But for value-based care, I think a lot more things need to happen. I think we almost need like an engine. Again, we talked about weighting people's intervention to say, you got a patient diagnosed with this, right? Number one, was the diagnosis proper? And there's a whole bunch of things happening with AI to look at the diagnoses, to look at radiology, to look at pathology, et cetera, to say, did you make the right diagnoses, doctor? And it's not to dictate, but to support their decision making and say, yep, you're correct. It's a stage 3 tumor of the pancreas. Check, you're good to go. So we need to be able to look at that data and say, was the prescription and the diagnoses made correctly? Then, and that's the doctor's responsibility. Then did the pharmacy dispense the right medication at the right dose, just in time to hit the need by date to make sure that that drug goes into the patient properly? Were side effects managed? That you know, if they take this drug or a combination of these drugs, you're going to have these sort of side effects. Did the pharmacy do their job to manage? Did a dietitian visit this patient and say, you know what, if you eat grapefruit before taking this drug, it's not going to work. So, and then there's healthy eating and healthy that supports, these kind of complex regimen. Did the dietitian come in and do their job? Each one of those interventions, each one of those adjunct providers, you should be able to wait and say you do X as a percentage of the total to promote a healthy predicted outcome. And everybody's reimbursement should be based on if they did the right thing or not. And that data exists. Everybody that does it, again, now, whether it's a practice management system, an EMR, diagnostic tools, everything's recorded. Prescribing systems, dispensing systems at the pharmacy, every one of those events is recorded. We just need to calibrate that in total to say, how does that match up on your weighted basis to promote a good outcome? And I think, we're getting to the point of quantum, computing to where that's possible. And I don't think it should be done, individually between a provider and a payer. I think it should be something systematically derived to where an answer is spit out by a third party. So there's trust in the system versus just a negotiated settlement. Those things are coming. So I think the data is going to be a key aspect. And it's so unfortunate we still live with 80s technology to use fax machines to transmit this data back and forth. I think it's going to come together in a way to where, quantum computing can spit out an answer to say, did they have an outcome? Yes, great. Now, what did you do to support that outcome? And your reimbursement is going to be based on how well you did your job. And when we come to that, and I hope it's within the next decade or so, which I think is very reasonable, I think a lot of the waste, the absolute waste of money that goes to chasing crummy outcomes, to chasing, stupid interventions are going to go away because people are going to be held to a standard. And it's not, like I said, an answer that is derived. It's going to be an answer that's computed, and there's going to be no argument. So I think that's the day things will really change.
I think speaking to the future and things coming together, I know we had discussed as well, the future that you might envision of, direct, manufacturing carrier
Mhm.
contracts. And so what, intermediaries, such as PBMs, wholesalers, do you think will really be affected by this intermediation? And what will that really look like as well?
Remember when you talk about PBMs and wholesalers, we're talking about Fortune 50 companies, and they didn't get there by being stupid. So I don't see them going away. But I think that you're going to have to start very holistically to say, what does the whole market look like going into the future? And I think what we've seen over the last few years is literally somebody with a condition, and the primary intervention has been to manage their symptoms and just keep them alive, right? That they can actually get through from day to day. And chronic disease and chronic patients have been what it is. And if you look at The older generation, look at all the drugs that they're on for diabetes, heart disease, etc. They're all generic medications, filled at retail pharmacy, pills, tablets, etc. That is morphing. That is going away. Okay. And that market was supported by wholesalers who have to go dispense and deliver 150 drugs to one pharmacy on a daily basis. Okay. PBMs had to sit there and pay for 150 scripts, for that pharmacy on a daily basis. So there's this massive volume based on the kind of medications, the kind of interventions that have been the traditional. So we're seeing that going away. Not only is demographically the baby boomers going away, but now we're seeing cures for disease, that we're seeing things like gene therapy, cell therapy, where there's literally a pharmaceutical manufactured for a population of one, to where they take your genetic makeup, they look at your markers and the different things that make you up from a genetic standpoint, and then they make a drug that's going to meet your tumor, your disease specifically. And so you're moving away from retail pharmacy and the generic pills, tabs, and caps. And you're moving to something that is more curative, infused, and cost $4 or $5 million for one episode. Okay, so that's the shift that's happening. So in that shift, who's going to be left standing? Who's going to be disintermediated? Or are they going to find ways to monetize their services in a different way? I think it's going to be the latter. I think, like we talked about with data, these people are data experts. If you look at the wholesalers, they all own huge, huge data segments to their operations. Take a company like Cardinal or McKesson. They have, a vast majority of their income is from data, providing data back to manufacturers, providing data about utilization to investors, providing data on a track and trace that this product originated in your warehouse, manufacturer came to my warehouse. I delivered it from my distribution center to these pharmacies. Here's the date and time stamp of that chain of custody, right? FDA requires it. PBMs have a ton of data. Take a company like United Healthcare. They have 35 million patients that they provide services to. They got data on 35 million Americans. And you don't think that's valuable? It is. So I think they're going to shift how they make money from actually doing tasks and doing singular services to more of a data and a data management. At least if they're smart, that's how I would pivot. The world is changing from maintenance medications to curative therapies. And in that shift, there's going to be more manufacturers that say, you know what, this drug is only going to go to these 20 centers of excellence that treat, pancreatic tumor. My drug's for pancreatic tumor, cures pancreatic tumor. Why am I going to put that into a whole, wholesaler, model that has full line distributions and is only going to 20 sites of care? I can deliver that directly and take out that entirety of that wholesaler cost when I'm only treating this niche disease, niche patient in this niche location. So as the market shifts, as the pipeline shifts, I think you're going to see less dependence on wholesalers and middlemen that just distribute product. It's not going to be needed anymore. It's going to be, more FedEx and UPS than anything else to make sure that the product gets there on time, even within cold chain and refrigeration and things like that. But you're not going to need, somebody like me that takes, 5 or 6 pills a day. You're not going to need that anymore. So as that shift happens in the pipeline and in the overall marketplace, the smarter ones will pivot. And I think the pivot is going to be on data and data management to support everything from value-based care to clinical research. If you had 35 million Americans data, you don't think that could be very supportive of somebody doing research in a certain tumor or a certain disease to say, look, I got this much longitudinal data on these patients as to what they took, what they succeeded on, what they failed on to support clinical trials. So I think there's going to be a huge pivot from actually doing tasks and delivering products to, filling claims to actually managing the data and hopefully towards value-based arrangements.
I know we also touched about, private equity as well and, them targeting. How do you think in this future that they're really going to be aligning themselves with, creating the right type of ROI timelines to, long-term patient goals in this future?
Remember what we talked about, 9 to 10% annual inflation, predictable and literally guaranteed, is something that private equity was absolutely all over. So I think they also need to pivot to say, if I'm going to look at this from a cost saving standpoint, because right now I think the impetus, societal impetus, is to say healthcare has to be affordable or we're not going to be able to sustain the provision of healthcare. Something has to give. So is private equity patient enough to sit there and say, I can predict a 9 to 10% inflation rate and gear my investments accordingly? That's easy. That's a simple pivot table to be able to do that. However, reducing costs is going to be much more longer term. It's probably got to double the sales cycle to sell something like that into the market. How do I invest in something that has that much of a question mark associated with it versus 9 to 10% year over year inflation that I can absolutely guarantee? So they're going to have to think a little bit differently because cost savings have to come. Cannot, say that emphatically enough because this is totally unsustainable. We cannot compete globally. Our companies, our employers cannot compete globally and have a 9 to 10% inflation rate on providing healthcare to their employees. You're also seeing the market suing employers to say, you providing healthcare, making that choice on who you choose and the benefit design means you're acting as a fiduciary. So if you don't choose the best and the most effective, you're violating fiduciary trust. Boom. That's kind of like the 401ks about 10, 12 years ago. That shifted the entire market. So we're going to see that coming down the pike too, to say that employers that provide healthcare to their employees have to do a better job. They cannot just trust the consultants. They just cannot trust the PBMs and the rebates. It has to be transparency. So all these things, again, present opportunity to people that are investing into this sector to say, I got to be looking a little bit differently as to what I'm investing in. Okay, first of all, what is the product and what is the product going to do? What is the growth rate associated with that product? And what is the monetization opportunities for that product in this market as it sits today? So I think they're coming around to that. We're seeing, like I used to go to JP Morgan healthcare conference in San Francisco for many, many years pre-COVID. And nobody wanted to talk to a company that said, I'm going to reduce healthcare costs by $75 billion, right? By automating prior auth. Nobody wanted to talk to us. Told us to go to hell. Today, post-COVID, if you're not digital, if you're not automated, you're not going to get the time of day either. So you're seeing a shift in just the mentality, but then you need to take that vision and the shift and then be able to put that into a table to sit there and say, this makes for a good investment. Here's when my return of investment is going to be at this sort of a rate of return. All those things, again, are being recalibrated as we speak to address the cost side. So I'm just ecstatic as all get out to see that evolution. And the more we can, promote that, I think the more savvy investors are already glomming onto that. And the rest are going to soon to follow. But they chased the inflation rate, man. They've been extremely easy for them to invest in healthcare before. It's getting a little bit harder, but I think they can handle it. I think they can come to something that's, we have a societal issue here too. That healthcare, again, is the most basic thing that we have. It needs to help society. How do we do?
I know you noted the investor appetite. I think, what do you think is some process that, in a post-pandemic world that was temporary, that you think can really help shift momentum in the market and where things are going to sustain all of this?
Yeah, I don't know. I don't know if there's anything that you could just remove or do away with that could, either stymie or help with the momentum or not. I mean, we're seeing things like telemed, for example. How hot was that during COVID? You saw companies just explode in valuation because they were telemed when everybody was on lockdown. Not so much. They're all now going out of business because Medicare has reduced reimbursement, commercial insurance has done away with reimbursement. So there's one that was literally a flash in the pan. It's completely gone. Same with masks, gloves, things like that were, again, just hot commodities during the pandemic. Now they're gone. I look at more systematically to say, what are those systemic, entrenched things that, again, if we were to move forward, need to be either bolstered or continued and enhanced in a way And I keep coming back to value-based reimbursement, that this is something that, we've been talking about it forever. I go to a conference called Assembia in Las Vegas, for 20 some years now. And for 20 some years now, they've been talking about the emergence of value-based care. And for 20 some years now, there's never been one single incident where that's actually been done in a way systemically to say you're going to get paid based on the outcome that you achieve. Hasn't happened. Why not? Because I think there's just too many perverse incentives for you to do the opposite, which is to increase the number of visits, increase the number of prescriptions, whatever it is on a volume basis to get paid versus getting paid on the outcome that the patient experiences. So I think, we need to kind of rejigger how we pay for healthcare. And it needs to start with the employers as they're kind of negotiating these kind of contracts to provide insurance to their employees. That needs to be part of the conversation. And I don't know if you know that decision point, but it's usually HR, human resources, making that clinical decision on who they choose to provide healthcare to their employees. I just don't see the expertise level, not to denigrate human resources, but we're talking about clinical things around value-based care. Are they able to negotiate and implement a health plan that actually promotes good outcomes versus just seeing it on a PowerPoint that bidder comes in with, right? So it's a lot of those kind of things that, again, we just need to kind of follow the money back into who's making these decisions, make sure they're educated. And I think the number one momentum that we need is to, again, promote from the ground up this notion that it's not tasks, it's not prescriptions, it's not volume that drives your reimbursement and your income. It should be that your patient that you're taking care of is better as a result. And so that mindset needs to shift. The data that supports all that needs to be attuned to that. And payers need to be calibrated to pay on that basis. But again, it's the employers that negotiate these contracts that need to come to the table first.
Your 2012, patent really talked about, the ChatGPT era. And so what do you think is something that, is missing in the guardrails for AI and patient engagement tools in today's market?
Yeah, I don't want you to think that we were so smart that we envisioned AI and ChatGPT that many years ago. But we truly, truly felt that patients and engaging patients into a plan of care was vital. We talked about, value-based and outcomes-based reimbursements. And if you were to look at how well a patient reaches that endpoint, there are behaviors that they have to do. There's copays that they have to pay. And all those things, if are not coordinated properly, they're not going to reach that outcome. So we felt that patient engagement was a tremendous, tremendous variable that we have to address and pay attention to. And again, that was in 2012. And then in the last few years, we're seeing this massive, massive migration to AI intelligence that is literally gathered and provided to you, whether you are a patient, whether you're a doctor. There's just so much information that's available. But one of the guardrails we see that is needs to be addressed, otherwise we're going to have a massive problem, is that while that information is great, the issue about who bears the liability for that is still unresolved. So if you're a physician and let's say, your carrier makes you do an AI check on diagnosis, for the AI to look at, the pathology or the radiology, look at your MRI, for example, and say, did you truly make a right diagnosis, that it is the right tumor, that it is a tumor? And based on the tumor type, that you're staging it properly, AI can provide a lot of input, right? But who's liable for that? If there's a mistake, is the physician responsible if they trust that information and make a clinical decision and it goes south on you? Who's holding the bag? And I think that was one of the things that we were cognizant about from day one, is that we didn't want to put additional burdens on the physician that is using our technology to somehow have an increased liability burden, right? So when we go out, let me compare that to ChatGPT. You put in a pancreatic cancer or something like that into ChatGPT, it goes out and searches the entirety of the internet and finds every relatable article or post about pancreatic cancer and brings that to you in a distilled format. It doesn't have the ability to say, okay, this article is peer reviewed, is published in a very, very impressive journal. It's authored by these doctors and clinicians that have an outstanding reputation, versus this one that's published by some guy wearing a tinfoil hat and it's literally his opinion. How do you distinguish between that? Well, ChatGPT really doesn't have that wherewithal to sit there and say, this one is good, this one's not. It brings everything together and distills it down. So what we wanted to do in comparison was to sit there and say, when we bring something to the physician that it's actionable, that it's based on data, that it absolutely stands, it's bulletproof. It stands every single credibility aspect. So we only gather data from payers. So if it's about a drug and what qualifies that drug to be approved on a prior auth, we go out and get Aetna, we get Humana, we get United Healthcare, we get everybody that is a payer that has run that drug through a P&T committee, that has done massive diligence on whether that drug is FDA approved, for what conditions, at what dose. They've done the work. So when we solicit that data from vetted sources, again, it reduces the liability if a physician acts on that. And then we look at the FDA. What did they put out to say, okay, this drug was approved at a dose of 10 milligrams per kilogram. But as it matures, we've seen that 8 milligrams per kilogram works just as well. And so the FDA might change their dosing parameters. There's a whole bunch of compendia that big entities put out, again, that looks at real life evidence and says, if you do it in this slightly different way, you get a better outcome. So we look at vetted sources versus just open sources to bring in the data. And so our goal is to really look at the liability issue. We don't want to push that on the doctor. If we push liability on them, then they're going to really balk at doing what technology suggests that they do, because there's a burden. It's a real cost. And we don't want to increase that cost. We want to reduce cost. So when we go out there and do what we do, we again pull from sources that's 100% vetted, trusted data warehouses, payers that have done it through their credentialing and through their vetted committees. It's documented. We look at FDA. We look at the data that pharmaceutical manufacturers submit to the FDA. So we only look at searching databases that, again, pose very little risk versus, like I said, the tinfoil hat dude that's out there saying this vaccine should, it's going to kill you or whatever. So we try to make that as a pivot, because otherwise we don't want resistance, just entrenched resistance to say, I don't trust you, man. I cannot trust you to put this into my plan of care because it's literally affecting people's lives. And so we wanted to remove that objection. So from day one, what we go on search is a very, very small subset of the entirety of the data that's out there. And we only give that information that is 100% vetted and approved. And we follow, for example, payers. Every quarter, they make decisions on what they cover and at what dose, what duration, et cetera, for drugs. We follow every payer's P&T because they do it quarterly. And if they make any changes, we make those changes that they do into our system and amend those policies and algorithms accordingly. So by keeping on track, again, to trusted and vetted sources, we're hoping we can reduce the liability on physicians and providers that use our systems.
I know, talking about burden as well, a lot of people have really had some interesting experiences with EHRs, or maybe have been burned as well. And so how do you guys really go about building trust without increasing the admin burden or creating new documentation tools?
Yeah, like I said, the first is just access, that it is within whatever workflow they're using, right? So we've been to doctors' offices that do the prior authorizations out of their EMR. That tends to be probably the vast majority, 60, 70, 75% use it out of the EMR. Some use practice management systems to coordinate the prior auth. Others literally use faxes and phones to do the prior auth. So regardless of where you are from a technology savviness, we should be able to engage you into our system. So first, it's just a point of access, that we have to make all points of access available without sacrificing security. So we do two-factor authentications and things like that to minimize security risks. But we have to make every aspect of access available for them to, again, not be burdened. And then in comparison to EMR, that is a documentational model. We want to take a transactional model that the documentation supports the transaction. So if you have the data in your EMR and you can scrape that data and then put it into a data table that matches up to what a payer wants to see when you request a drug or a service or a procedure, the formatting of that is really important. It has to be in the way that they want to see it. Exactly. Are they going to say it or deny it, right? So we support the documentations that are within the EMR, and we've developed a way to scrape the data that we need to be able to fill in, for lack of a better word, a form, to submit that to the payer in exactly the way that they want to see it. And then on top of that, our system is a very learning system. So when you submit one and it's sent back and says, I need more information to approve this drug for this payer, the system learns. And the second time, it says, okay, the first time I sent it in, they wanted to see this lab result. They wanted to see that they've tried this drug first before going on this expensive biologic. So the second time it sends it, whether they ask for it or not, proactively. So it's a continually learning system that every single transaction then defines how the second and the third and the fourth are staged to get to 96, 97% first time approval, which is the goal. That when you submit it the first time, it should be approved because the payer's seeing and getting everything they want to see. So we want to make that as part of table stakes to say, if you cannot give them access in the way they want it within their workflow, and you cannot learn and submit only the things that the payers want to see to promote a good outcome, again, you are selling yourself short. That has to be there. But at the end of the day, these doctors, again, remember, a doctor got into business to treat patients. They didn't get into the business of being a physician to shuffle paper. So it is absolutely against their wishes to be able to, are being forced to shuffle paper. So we understand that. And so I think the trust comes to where they try it. They know what they did before when they faxed it in and then phone the payer and say, where's my approval? It's been 7 days. And back and forth, back and forth. They understand that process, the time, and the cost of that. So when they see us and they use us, they can pretty quickly verify that there's an efficiency that we bring to the table. And if we promote good access and then also, again, give them good information to make this go through, they're going to see a positive ROI. But we don't assume that first time or even from our sales that a physician or a clinic is going to adopt. It has to be after they've tried it and they've used it and they see an ROI. So yeah, we have a prolonged sales cycle, but again, that's the way it should be, especially for something new, that it has to be something that's proven in their practice and in their use case for their patients before they fully adopt. So it is what it is.
With your work at MedTech, if you guys really, achieve your goal of extracting billions of operational cost, what metric will really define your guys' success in patient access and outcomes?
Yeah, we've kind of struggled with this. We want to save money. We want to make processes more efficient to where physicians and clinics spend more time with their patients and less time on administrative hassles, right? They make you jump through a lot of hoops because these drugs cost so much that they want to make sure you, doctor, really think that this is the only drug that's going to help your patient. And if you don't think that, try something else. And for you to come to that conclusion, the more hoops you have to jump through, the hope is, or the theory is, that you'll be much more thoughtful about wanting to use this expensive medication. Well, that drives up cost. And so if we attenuate that in any way at all and shorten that, then, there's going to be savings. But what is the market going to do with those savings? And I think, again, it's not for us to decide that, but the hope is that, from a physician standpoint, if they save money, again, they are paying more attention to patient care. And back to the outcome piece, if they're spending less time shuffling paper, will they do more to help that patient achieve that outcome, right? If a clinic or a hospital saves money in administrative hassles, will they put some of those savings not in their pocket, but into promoting good outcomes, patient engagement, outreach, whatever it takes. If pharma has less abandonment and they save money and they raise more revenue, are they going to put it in their pocket and give dividends to their shareholders? Again, rightfully they can. But are they going to look at maybe reducing the overall price to say if my brand generates $1 billion, and now because of these technologies I'm able to achieve $1.2 billion in revenue at the same cost? That's incremental profitabilities. What am I going to do with that? The hope is that they reduce the overall price of their product. So again, all we can do is go out there and use technology and efficiencies to save money. What the market does with that, again, we cannot control, but the hope is they put that towards better outcomes and outcomes management, towards, again, reducing the out-of-pocket costs, because one of the reasons patients stop with their medications and take a vacation is because they can't afford it, right? If you got a 15, even 10%, make it easy. Say you got a 10% coinsurance or copay on a drug that costs $5,000 a month. We're talking about $500 a month. That's a car payment. And so if you can't afford it, what are you going to do? You're going to not take that drug and not fill that prescription, even though you need it for the rest of your life. So if that manufacturer, taking some of these savings, can reduce that out-of-pocket cost or subsidize that out-of-pocket cost in some way, again, the patient should be able to afford their meds, stay on their therapy, and finish the therapy and get a good outcome. So that's what we hope, is that as the market sees these efficiencies and saves money through the reduction of operational cost and administrative costs, that savings is somehow put back into the system to promote better outcomes and better healthcare. And everybody wins in that scenario.
Perfect, perfect. Now, Bob, it's time for us to go to the lightning round. And so my first question for you is, what is an overlooked operational cost sink in healthcare that you think could be immediately eliminated with tech tomorrow?
That's a great question. There's just a lot of sunk costs, but I think the one that comes almost immediately to mind is how much of healthcare runs on call center. A lot of them are like overseas in the Philippines and India and places like that. But every entity, whether you're a pharmaceutical manufacturer, if you're a hospital or whatever, you got phone calls coming in and you have outbound phone calls going out. And they're typically done with butts and seats, that every time the volume grows, you're going to have to add more people. And it is a really, really kind of a stupid system because it marginalizes, the patients and the patient's experience. Same with physicians and their experience. It's awful. But that's how things run today, that you onboard the patient. So you have to talk to somebody and say, okay, give me this, give me that. Here's your copay, coordinate that, and then get them started on therapy. And then we're talking about chronic therapies, lifelong therapies. So you have to call the patients and say, how are you doing? Did you have this side effect? Did you have that side effect? And then you have to submit transactions to sit there and say, okay, I need a prior auth for you to get next month's drug. So I have to submit this paperwork. All that is run on a call center. And so we have a variety of technologies to inbound those.
And my next question for you is, what healthcare middleman do you think will still exist in 2030? And what will their value prop be?
Wow. That's a great question, and I'll get out my crystal ball. But I would say just very, very high level. There's a lot of middlemen, middle persons, whatever, that provide very little value. And I think if you look at it from that standpoint and say, what do you bring to the table that actually provides value? If you can't answer that question, you're probably gone. So if you look at the different sectors, if you're a PBM and your entire reason for living is to monetize rebates, guess what? You're probably going to be gone. If you're a wholesaler and all you're doing is monetizing generics to subsidize the branch, and you're playing games with payment terms and all that kind of stuff, you're probably going to be gone. But if you truly want to re-energize your business to be around past 2030, et cetera, I think it's really to say, I touch you in these ways, whether you're the customer or, some other entity within healthcare. My reason for existence is to touch you in these ways. And if you do that with more data and more data-driven activities that provide value, that actually enhance value, especially around outcomes and promoting good outcomes, you should be viable. And it may require you, for example, the wholesalers each operate 30 to 40 massive distribution centers around the country to support retail pharmacies with pills and tablets. If that goes away, do you need all of that? So it could be where you need to downsize and look at recalibration of your business that says, look, I don't need to distribute pills and tablets anymore. It's moving to infusions and these cures versus maintenance medications. So I'm going to live on the data. I have the data. So I can help pharma. I can help them with their clinical trials. Or if you're a PBM, I can actually help you, employer, make sure your employees show up to work because they're not sick, they're not ill. And I can help you help your employees reach better outcomes. That provides value. So it needs to be data-driven, and it needs to be really focused on improving outcomes. If you can do that versus just, to your point of being just a middle person taking margin and providing no value or low value, you're probably going to be extinct versus the people that survive are going to be the ones that are much more actionable with data.
Beautiful. My next question for you now is, what, 2020 era, innovation do you think can happen or something that needs to be removed from, that era to really bring about changes in healthcare?
A lot to unpack with that question. If I was to look back on 2020, the COVID era, it seemed like we did. How do you remove, from acting out of fear? And so I think the same thing can be looked at today, post-COVID, to say, what is the fear we're living under? The fear is that healthcare is unsustainable. The cost of it is escalating so fast that our companies and employers cannot compete globally given that cost exposure. And that's a fear. It's a real fear. And then we have people, again, also fearful that they're going to get sick and they're going to, end up with all these costs that bankrupt their families. Again, we're acting out of fear. So I think we need to remove that mentality and actually look at this proactively and say, yeah, we got the money. We're the richest economy in the world, and we're spending it, but we're getting crummy outcomes. And so that shouldn't cause fear. That should give you an opportunity to say, we got the resources and the money. Why are we not, calibrating our entire healthcare systems towards outcomes versus activity? And so I think, we got to recognize the fear. It is real, it's palpable, but we're a smart country, probably the most innovative country, based on the number of drugs and services we innovate. We need to attune that innovation towards solving for outcomes. We're spending the money, and by God, we should be expecting just as well for the outcomes to be in par with the spend. So let's kind of, quit scaring ourselves to death. Nobody's going to die, that's not already going to die. But we need to change our mindsets to say we can solve. We can solve for this. And we can solve for this with our brain power and our proclivity for innovation. And nobody's done that better other than the Americans. And so I'm confident that we're going to solve for this by 2030, as you kind of put out there. In 5 years, can we move to an outcomes-based model? I think we can start with some of the more common drugs and common disease states and start for that. We can start educating people to do the right behavior to prevent disease. And I think once you have a disease, again, innovation is there to help you with drugs or procedures that can help you. But it all gets down to, is that spend calibrated to the outcome instead of that spend being equated to tasks and, shuffling paper or doing more just to increase the reimbursement versus truly saying, I got paid because my patient got better. So if we can move that mindset, I see nothing but possibilities, and I think Americans deserve that.
Perfect. Perfect, Bob. Thank you for your time and your thoughts. You've been very helpful, and I love the perspective that you have. Maybe what are some final thoughts that you have for the audience?
Get engaged, folks. I think the era of consumerism is going to transcend into healthcare. It's probably the last sector, but it's coming. get engaged. I think the more you can engage with any and everybody you touch, whether you're a supplier or you're a provider or any or a patient, get engaged, because there's nothing more that you can do other than to educate yourself and don't be dependent. Actually be an active consumer of services and take some responsibilities. Like we said, 50% of the stuff is preventable. So if we can reduce the cost by 50%, where will we be economically? So a lot to think about, but I think, the era of consumerism and is coming, and it's going to explode in healthcare with ChatGPT and AI and all these things to support us. We have no excuses anymore. Let's get with it.
Perfect. Thank you. Thank you again. Where can people choose to connect with you as well if they choose to do so?
Yeah, my profile's on LinkedIn, so feel free. It's probably the best, and I check it pretty regularly. And MedTek RX is our company. You can check out our website as well.
All right. Thank you, Bob, for your time, of course.
Thanks, man. Appreciate it.